All right. Well, good evening, everyone. We'll go ahead and get started. And just to let everyone know that's joined in that this session is being recorded and will be made available to those that are interested afterwards. Thank you for taking out time out of your day on a Sunday evening, or perhaps it's a Monday, depending on where you are, to participate and listen in on this panel discussion. We have a fantastic panel assembled here to talk on an issue we think of significant importance. Many of you may have seen a draft report in the U.S. That's been issued by the Agency for Healthcare Research and Quality. If we go to the next slide. And go to the next slide. And next slide. So this is a report that was commissioned by the Center for Medicare and Medicaid Services. And as part of this report, there were two key clinical questions that were asked. The first was, what is the efficacy, effectiveness, comparative effectiveness, and harms of CPAP devices to improve clinically significant outcomes as it relates to obstructive sleep apnea? There was also a second key clinical question that CMS asked AHRQ to obtain answers to, which is, what is the evidence that apnea and hypopnea-based measures of sleep-disordered breathing, for example, apneic indices, hypopnea indices, the AHI, used in current practice and research, and are they valid surrogate or intermediate measures for clinically significant outcomes? There were a number of contextual questions as well that was asked within this framework that the authors of the report also attempted to answer. But these were the two key points that the report was aiming to answer. Next slide. The methods that were used in terms of approaching these questions really were to focus on studies that involve randomized control studies and certain non-randomized cohort studies that did allow for adjustments within the studies. Ultimately, in terms of the studies that were restricted, they looked at studies that allowed for 1-year follow-up for outcomes of death, incident cardiovascular events, incident hypertension, and incident diabetes. For other outcomes, they allowed for a 6-month follow-up time, such as motor vehicle crashes, mental health conditions, cognitive functions, quality of life, functional status, sexual function, sequela of sleep deprivation. In all, they identified about 47 studies, of which 25 studies compared CPAP to no CPAP. And of those, 12 were randomized controlled trials and 13 were non-randomized cohort studies. 14 were identified as using intention to treat analysis, and 11 had analyses comparing users to non-users. Next slide. The conclusions of the report were as follows. First, that studies are highly consistent as how they define breathing measures, such as the AHI during sleep studies in obstructive sleep apnea. The second was that they thought that there was insufficient evidence present in the literature to assess the validity of the AHI as a surrogate measure of intermediate outcomes for long-term clinical outcomes. Changes in the AHI should not be assumed to correlate with changes in long-term outcomes, was one of the conclusions. The third conclusion was that CPAP does not affect long-term clinically important outcomes, which has probably raised a lot of consternation amongst this community. Number four, the fourth conclusion was studies did not adequately address whether effects of CPAP vary based on disease severity, other patient characteristics, different features or modes of CPAP, or different criteria or definitions of sleep measures or OSA diagnosis. And the last conclusion was that additional studies are needed about the potential effects of PAP on long-term outcomes and whether the AHI is indeed a valid intermediate or surrogate measure of these clinical outcomes. Next slide. So in terms of, really the focus of tonight in part is to really have a discussion about some of the research gaps, both identified by the report, and really to take this as an opportunity to think about, the path forward in terms of a research agenda. If you can go to the next bullet point. So one of these is that that the authors made was that adequately powered, high quality, long-term RCTs are needed to evaluate the effect of CPAP on clinical outcomes. One of the questions I think that'll come up hopefully during this is, what does high quality really mean with respect to this? Next point. RCT should be powered to evaluate differential effects of CPAP based on factors such as the baseline AHI, patient symptoms, and other characteristics. So this really goes to the issue of, selecting the right patient populations for studies. One of the issues I think we'll talk about during this discussion are there issues with randomization of certain groups, and are there other designs we should be thinking about? Next point. Better reporting of patient eligibility. So this was one thing that the report identified. How do we define sleep apnea at this point? Are we doing an adequate job with respect to it? And so one of the questions I think for the panel tonight is there a standardized approach the field can implement, or are we there and maybe the report missed something? Next point. And finally, studies are needed to assess the validity of AHI sleepiness scores as surrogate measures for long-term outcomes. And I think the real fundamental question is, what should these studies look like? Next slide. So, to respond to the draft report, the American Academy of Sleep Medicine coordinated with other societies to develop a response written by a writing committee. The moderators that are on this discussion tonight, my colleagues include Dr. Peter Gay from the Mayo Clinic, Dr. John Kimoff from McGill University, Dr. Alan Pack from the University of Pennsylvania, and Dr. Karen Johnson from UMMS Bay State, and myself, Sushil Patil from Johns Hopkins University. Although the AHRQ draft report tone is disappointing, misguided in some areas, like many of us would say, the report does bring up a number of issues regarding the research agenda on sleep apnea that moving forward that we should talk about tonight. A panel discussion was thought to be another stop, if you will, in the continued approach across stakeholders to start a dialogue of what the research agenda should be for sleep apnea. And to help address these issues, we have a number of esteemed colleagues who will present their thoughts tonight. And those include Dr. Susan Redline from Brigham and Women's Hospital, Dr. Dan Gottlieb from the VA Boston Healthcare System and Brigham and Women's, Dr. Doug McAvoy from the Adelaide Institute for Sleep Health Research, Dr. Greg Maslin from the University of Pennsylvania, and Dr. Patel from the University of Pittsburgh. Next slide. So the agenda for this evening is as follows. We have 5 sections, if you will. Each session is going to be 20 minutes in length. We will have each panelist speak for about 5 minutes and then use the remaining 15 minutes of that section to answer questions that the moderators have, as well as the attendees. We ask the audience to go ahead and enter questions into the Q&A section, which you should hopefully be able to find at the bottom of the Zoom. There should be a button there that you should be able to click, and you should be able to enter your question in there. The chat we would ask to just reserve for technical questions or general discussions with each other. You can use the private function to communicate with others if you would like. And if the moderator feels it's appropriate, we might ask an attendee to be able to unmute themselves and maybe make a clarification for a particular question that may be answered. So without further ado, we'll get started with our first section with Dr. Redline, and we'll have Dr. Peter Gay introduce that section.
Thank you, Sushil. It's a pleasure to be part of this panel and this august group. I'll just mention, to reiterate what Dr. Patel was saying, that the AHRQ report was commissioned by CMS to investigate issues regarding the outcomes for OSA, and AHRQ is still the good guys. Now, remind the audience or alert the audience that the authors are actually present to this. So with that, we're going to kick off the alternatives to the AHI that were brought up in that report with Dr. Susan Redline, from the Brigham and Women's Hospital in Harvard. Dr. Redline, please.
Yeah. Thank you so much. Next slide. So thank you so much for bringing us all together tonight. And to begin with, I want to first acknowledge three amazing people, Ellie Zarbin, Scott Seans, and Andrew Wellman. And it's been an absolute fantastic journey working with them and having them apply their physiologic methods to large epidemiologic studies. And I'm going to review with you some of the work that they have done and have informed this talk. Next slide. Next. Okay. So to begin with, as we think of alternative metrics, let's think about what an optimal disease metric is. And so it should identify disease and grade disease severity. So for sleep apnea, what is experienced is recurrent ventilatory deficits over the night. So we need a metric to quantify that physiologic abnormality, and it should be specific and sensitive. It should be appropriate across populations, including across ages and in men and women and comorbidities. And we need to understand the ability to characterize that metric in sort of its dose response characteristic and have valid thresholds for our populations of interest. Moreover, the metric should have short-term reproducibility, but long-term, it should be sensitive to those interventions or changes we're most interested in. And because sleep apnea isn't one disease, I firmly believe it's many diseases, we should be able to combine that metric with other metrics and information to subclassify disease subtypes. And for the purposes of research, we need metrics that predict adverse outcomes in treatment responses. And as you can see on the right side of the slide, where we have images from the polysomnogram, any given AHI may vary dramatically in terms of how it characterizes that depth and duration of ventilatory abnormalities, as well as the dispersion of events across the night. Next slide. So on the left, so the AHI on the other hand is, it's a simple frequency count, how many apneas and hypopneas per hour is experienced. And over the years, it's been fairly useful for a number of purposes. So for example, on the left-hand side of the slide, we see the hazard ratios from 3 of the Sleep Heart Health Study data. And in Black and men, we see positive hazard ratios predicting moderate to severe sleep apnea is associated with cardiovascular disease and mortality. In red, however, we see those same hazard ratios in women, and we see much less consistent findings. So we've been wringing our hands over many years, recognizing that this simple frequency count is an incomplete measure of disease severity. It really tells us very little about the collapsibility or the degree of ventilatory obstruction. It doesn't distinguish that phenotype heterogeneity, that is the contribution of anatomy versus various physiologic properties. It does not directly measure those intermediate pathways that may lead to disease, for example, autonomic nervous system dysfunction. And usually we take an AHI at one point in time, and we have no idea usually whether that is a measure of a recent disease or disease that's has been present for many, many years. And finally, we all know the challenges in measuring the AHI and some of the subtleties on how hypopnea measurement differences may lead to vastly different mean levels, but nonetheless, we persist in using multiples of 5, an AHI 5, 10, 15 to grade disease severity. And there's obviously measurement error, laboratory error, human error over time. So in other words, the challenge is that the AHI may not capture our key physiologic disturbances, distinguish subgroups, or predict susceptibility or treatment responses. Next. Next slide. So let's think about some alternatives, candidate metrics. And I'm going to begin by actually taking more of a clinical perspective before I go into research. So let's think of asthma. patient that we're interested with asthma will present with typical symptoms of cough, chest tightness, wheeze. And then the clinician will get corroboratory physiologic data to support their diagnosis and exclude other problems, like a spirometry, bronchodilator response, peak flow measures. And I will submit that we clinically, to define the disease, we begin with symptoms and we allow ourselves, depending on the setting, to use a number of confirmatory physiologic measures. It could be that frequency count, the AHI, but being clear that we're using the right AHI for the age and gender population, but also looking at how we quantify those ventilatory deficits, ideally using an airflow-based metric, which right now is challenging to use because of the limitations in our collection and analysis approaches, but possibly we could use surrogates of ventilatory deficits. So Andrew Wellman has suggested that the median decrease in saturation as seen in the upper right-hand side of the slide, and the nadir maybe get a good measure, and Ali has suggested the sleep apnea associated hypoxic burden actually is a ventilatory deficit surrogate. But then when we go into disease mediators, we need biomarkers of susceptibility. What are those pathways that connect sleep apnea to those end organ health outcomes? And one of the obvious ones is autonomic nervous system dysfunction, with one of the more simple and readily available markers is the simple heart rate response to each apnea and hypopnea. And again, Ali Azarban, in the bottom part of the slide shows the people with the same AHI may have remarkably different heart rate responses to each apnea. And if you look further toward that matrix there, you can use a combination of classifying the AHI or the hypoxic burden, and then you layer on that heart rate response, and those with the delta heart rate responses that are high have a much higher rate of experiencing cardiovascular disease. But there are other measures available in the PSG, particularly from the pleth waveform, that may give us blood pressure responses, peripheral vascular responses, and they all are fertile ground for investigation. And then lastly, in this, there's the issue of markers of endotype differences, or the extent to which the etiology of sleep apnea differs across our population. As I said, it could be related to anatomic problems or various physiologic problems. So those are more difficult to obtain, but we know that event duration correlates with arousal threshold, apnea-hypopnea ratio correlates with collapsibility. But as we go forward, the use of automated techniques, for example, is developed by Scott Sands to actually extract measures of collapsibility or loop gain arousal threshold, certainly will help us subclassify our groups of patients. Next slide. Now let me get back to that old AHI. I don't love this AHI, but I'm not ready to completely ditch it. So recently the ASMF awarded Ali and myself a grant to really look across multiple large data sets and multiple outcomes. And what we did was we took data in three large cohorts, the MESA study, the Mr. Oz study, the Sleep Heart Health study, and we looked at dozens of different variations of how you can calculate the AHI by varying the level of desaturation, arousal, and other features. And in this slide, we see that there is, could you go next, because I have some information. We see outcomes, that is the odds ratio for diabetes in red, hypertension in green, and sleepiness in blue. And what we found was, not surprisingly, that it didn't make a heck of a lot of difference if we defined hypopnea as using a 3 or 4% DSAT. But surprisingly, what we found is that we were more strongly predicting each of these cross-sectional outcomes, as well as incident cardiovascular disease, when we excluded from events that did not have arousals. Completely surprising to us. And that led us to look in both the literature and more deeply in the data. And we do find that individuals with lower respiratory-related arousals have high rates of AFib. In women, they have increased rates of stroke, and there's increase in white matter disease of the brainstem. And when we looked at our longitudinal data, we found that severe sleep apnea at baseline actually predicts a greater decline in the arousal index over time. That is, although the arousal index is a great measure of sleep fragmentation in some ways, in other ways, it may actually be confounding us. It actually may be part of a pathological response to apneas or an index of adaptation over time, and thus possibly a surrogate for the duration of untreated apnea. So that is perhaps a high, arousal index will identify people with more recent disease in whom maybe there's more reversibility, and they may be good to include in clinical trials. However, the low arousal related index may actually be more fruitful when we look at observational data. Next slide. So let me just summarize and ask the audience some key questions. And that is, what is our single or combination metrics of disease presence and severity? I put out the idea that we can retain the AHI, although refine its use in the population of interest, combining with a ventilatory deficit metric. I think one of our key needs is to improve how we collect and analyze airflow, although until we do that, these measures of hypoxia may be reasonable surrogates. Then as we think about risk stratification, who do we include in these clinical trials? I think that event-related hypoxic burden, autonomic nervous system response as measured by the heart rate response seem to actually give us some intermediate mechanisms of relevance. I think there is opportunity to refine that hypoxia profile because there's subtle differences in how hypoxia may trigger downstream effects. And there's also the opportunity to actually combine, I've talked mostly about PSG data, but combining PSG data with symptoms and omics data, and some very exciting work done by Tamar Sofar in our group has recently trained a metabolomic risk score using PSG data and symptoms separately in men and women, and showed that this gender-specific score better predicted incident diabetes and hypertension than any other metric we've looked at. So, and then finally, we of course need to think about targeting specific outcomes. And then finally, let's think about when we predict treatment response, these diseases are heterogeneous, and therefore we need to think about, what are those surrogates for heterogeneity, how we could incorporate endotype measures, use composite scores. And then on the right-hand side of the slide, I just also leave you with the urgent plea not to forget that gender may be one of the biggest stratifying factors in terms of refining metrics that really reflect precision medicine. Thank you.
Thank you, Dr. Redline. You provided us with a number of thoughts here in terms of some of the questions that are coming up. They're just starting to populate, but maybe I'll ask you in terms of particularly the combined issues that come up, is it reasonable to ask us to talk about one OSA patient and outcome and one particular marker for this, and then to predict outcome? I think your answer is no. So how would you put together maybe a combination, and what endotype would you pick to be most responsive to predicting that outcome?
Yeah, so again, I this is obviously, we need to, really think carefully about this, and I don't want to be glib in my answer, but I think there's been a long-term concern or biological reasons to think that those who may be at most at risk for cardiovascular disease may be somewhat different than those at risk for diabetes versus cognitive impairment. And I don't think that that is this unique for our field. So I would begin by, thinking carefully about what is most important for us to predict over time. And when we design our studies, so again, there's different clinical versus research issues, but for research, I would define a fairly homogeneous outcome and then biologically identify those biomarkers that we think are in that pathway and then enrich the population using those metrics. So for example, if it was heart disease, I would enrich the population with a measure of ANS response to apneas and hypopneas.
So the use of autonomic markers has been a particular attraction to some of the manufacturers, particularly taking advantage of home sleep apnea testing, which doesn't have the EEG advantage for arousals and trying to make more out of the heart rate response. Where do you think this might go?
Yeah, so, again, I think one of the beauties of looking at a heart rate response is, so I think is that we don't necessarily need the EEG data. And as I also said, clearly indisputably, we need the oxygenation data. I mean, I think that's fundamental surrogate, for ventilatory deficits, and it's related to the mechanisms leading to disease. And with a good oxygen saturation measure, we could get that pleth waveform and get heart rate changes, but also get changes in vasculature and maybe even infer changes in blood pressure. So I'm really, really in favor of focusing on getting as much as we can from the oxygen saturation measure.
Well, the advantage of the home sleep apnea testing, of course, is that the volume is getting higher and higher. And one of the AHRQ authors that we had the delight of audience with after this, the authors noted to the panel that a registry would be most useful to look at some parameters. And if indeed this data is out there and often being broadcasted, there's a real opportunity to create this registry. How might you take advantage of that?
Yeah, I would potentially go a little further. And I think one of the things I would ask the Academy to do is to make part of its certification of sleep labs the requirement to actually deposit, core data in such a database or registry. And I think that this is and I know, this is something that's been talked about for many years, but we need to really learn from what we're doing day to day, have the data in a sufficiently structured format that we could use it, and that it could be integrated with the EMR in an efficient way so we could actually begin prospectively, asking some of the questions that we're grappling with today.
I wonder if Alan Pack of our panel might have a comment to share with you. Can we unmute Dr. Pack, please?
Okay, can you hear me?
We can.
Okay, Susan, that was great. Now, you mentioned that you're looking into the how these different metrics work in 3 population-based cohorts: sleep, heart health, Mr. Odd, and MESA. And I just wondered, I mean, there are some evidence that maybe people who identified in population-based cohorts are somewhat different to what we see clinically. And I just wonder, do you believe we have all the resources we need in this field to answer the questions that you proposed? Is it sufficient, do you think, to rely on these population-based cohorts, particularly since the sleep heart health? I mean, the average age, the median age was 65 or something. So I just wonder what you think about that.
Yeah, good question, Alan. Thank you. So, I think we need multiple sources of data. The cohort data, have numerous strengths. For example, with the MESA data, we have Hispanic community health data, we have omics data, that you'll never get, routinely in a clinic. And, we could begin to look at and we also have, very, easily minimal data to create endotypes. So there's some, and I think ultimately, there is a wide range of physiology, but I absolutely, as I said just 2 minutes ago, I think that the Academy should require every sleep lab and clinic to deposit data into a central repository, because those data will be highly complementary. So it's never an either or, but it's how we leverage leverage different sources of data to actually learn the most we can.
Well, thank you, Dr. Redline. I'm going to turn this over to Dr. Patil now to move us along. And that was a very exciting kickoff for us. Thank you.
Yeah, Susan, I actually had one more question for you, actually, before we go to Dr. Gottlieb real quick. I mean, we've talked about alternative metrics, but was just curious what your thoughts are in terms of, still, looking at the AHI and thinking about it, and whether one of the issues that maybe we as a field have not done a good job of is incorporating some measure of adherence into that in terms of these long-term studies. In other words, should we be looking at, rather than sort of change in AHI, but some people have used as a disease alleviation or a effective AHI measure?
Oh, yeah. So I think when I didn't. Yeah. So I think in the context of a clinical trial or clinical interventions, I think it's very, very important for us to understand how our target metrics are responding to therapy. And, clearly, and I'm sure Dr. Patel will talk more about this in adherence, I think that we often assume a 4 or 5 hours use of CPAP, for example, has eliminated the disease, and clearly that's not the case.
And there's actually one additional question from Dr. Bhajan Singh. So he's asking here, the idea that arousal frequency may decrease with disease duration is interesting. If this is confirmed, should we be exploring long-term outcomes in individuals early in the course of disease? For example, younger individuals. He noted that RCTs of CPAP on cardiovascular outcomes like the SAFE study were conducted in fairly older subjects.
Yeah, thank you for that question. I mean, I think one of the huge limitations we have is when we enroll people in a study, we have no idea of how many years they've had sleep apnea. And one of the big deficits in the field, and this is something that actually our research cohorts should we get funding to do, should be to do more longitudinal assessments beginning early in life, so we understand the natural course of these diseases and understand things about cumulative exposure. And so just as an example, in Sleep Heart Health, we initially did not see any relationship between coronary artery disease and heart failure outcomes in women versus men. And that was when the women were a mean age of about 64 years of age. So if they got their disease, later than men, they may have only had the disease for a few years when we actually measured the outcomes. So what we did a few, 8 years later is we actually updated the analysis, and we had 14 years of follow-up. And with 14 years of follow-up, the woman actually had a stronger association with heart failure and death than the men, indicating that it's really, cardiovascular disease is a chronic disease. It takes years of exposure, and we do need metrics of exposure. I am really intrigued with the idea that maybe the arousal index will be a surrogate, but it also could mean it brings some response that has nothing to do with adaptation, although I think it may have something. So we need further work this way. And, and maybe ultimately it will be a metabolomic marker or even some polygenic risk marker that will tell us something about cumulative exposure.
Thanks, Dr. Redline. We'll go ahead and move on to our next session or section at this point. So we have Dr. Dan Gottlieb from Brigham and Women's and Boston VA. And this section is going to be discussing targeting appropriate study populations in obstructive sleep apnea.
All right, thank you, Sushil. Can we advance the slides? So when we're talking about targeting patients for inclusion in research, I think we need to refer back to the Belmont Report principles. The first being respect for persons, and I think that's pretty straightforward. We can't enroll people in research unless they understand the research and agree to participate. Justice is the second of those principles, and in addition to meaning that we shouldn't exploit vulnerable groups for research, it's also important that the benefits of research be justly distributed, and that mandates inclusion of diverse groups who are likely to benefit from the research, and that's We just talked about men and women who might have different responses or not, but we won't know that unless they're both included. And I think this relates also to certain minority groups that which there's mixed evidence that, for instance, in the United States, African Americans and Hispanics may have higher risks of sleep apnea than others. So I think it's important in designing this research to pay attention to including diverse populations into the research. But I think it's the third principle, beneficence, that's really most relevant to the discussion today. And beneficence means that, well, to begin with, you don't do research that you know is going to harm people. But since you can't always avoid harm in doing research, there's always that risk. It's important to maximize the possible benefits and minimize the possible harms. You have the next slide. And I think this is very closely related to the concept of clinical equipoise, which was defined as uncertainty within the expert medical community, not necessarily on the part of the individual investigator, about the preferred treatment. I think that there has been, within our field, many who feel that anyone with sleep apnea needs to be treated, and we can't do a study in which we don't administer CPAP over a long period of time. But I think the AHRQ statement makes a very compelling case for clinical equipoise with respect to the cardiovascular and metabolic benefits of sleep apnea treatment, which I agree are at this point far from proven. If you have advance. However, I think it's also quite clear there's not clinical equipoise with respect to the symptomatic benefits of obstructive sleep apnea for patients who have symptomatic sleep apnea. And that has led to the exclusion of sleepy patients from most of our long-term outcome studies. Have the next slide. But sleepiness, there's a growing body of evidence that sleepiness predicts many of these outcomes that we've been interested in. For instance, in the Sleep Heart Health study, Vishesh Kapoor showed that as severity of sleep apnea increased as measured by the AHI, that among sleep apnea patients, there was a markedly increased risk of hypertension, but among those who were not sleepy, there was no association of hypertension with sleep apnea. More recently, Begumzadi showed in the Sleep Heart Health study data that a subphenotype of sleep apnea was characterized by excessive sleepiness, was associated with a significant risk of incident cardiovascular disease over a number of years of follow-up, but that non-sleepy patients with sleep apnea, not patients, but in this case, as a general population sample, but those who had sleep apnea but were not sleepy did not have a significantly increased risk of cardiovascular disease. And in the bottom right there is a study, I believe this is from the Philadelphia area, showing that among elderly people, those with both sleep apnea and excessive sleepiness had increased mortality, but that having sleep apnea without excessive sleepiness or excessive sleepiness without sleep apnea was not associated with excess mortality. So the exclusion of sleepy patients from these long-term outcome studies very likely biased these studies towards a null result. And I think that raises the question, are we targeting the appropriate group of patients to include in these long-term outcome trials? Okay, the next slide. So how do I identify an appropriate study population? I think there are some very general approaches. One is to start out by targeting the most severely affected individuals. If we're using the AHI, maybe an AHI of 15 is too mild, particularly given the fairly liberal definitions that we use for identifying apneas and hypopneas. But start with a more severely affected group, and then gradually, if we demonstrate an effect there, then gradually expand that to less and less severely affected individuals. It's an approach that's been very effective in evaluating treatments for hypertension, for hyperlipidemia, and I think that it would make sense in sleep apnea as well. I've got the logo up there from the Apple study, which I can pick on as an investigator, but this was a study looking at whether treatment of sleep apnea with CPAP would improve cognitive function. And overall, it was a negative study. But if you limit the sample to the most severely affected individuals, there was evidence of an effect. So I think that you may have missed an opportunity because of the study design there. Can we advance? Another is that where we're thinking about a condition that's reversible, such as sleepiness or depressive symptoms or high blood pressure, probably cognitive impairment, that rather than going to a general sample of everyone with sleep apnea, identify individuals who have that impairment to see whether it improves. If you have a group of participants that's not sleepy, it's going to be very difficult to demonstrate improvement in sleepiness. And I think, again, looking to the Apple study, we had a lot of participants who overall the study sample was not particularly cognitively impaired. And so we may have been hindered in trying to identify an improvement in cognitive function. And advance. So, and then finally, I would say that where possible, we should not automatically exclude patients who are sleepy or otherwise symptomatic. And refer back to the Belmont report, which says that learning what will in fact benefit may require exposing persons to risk. And I think that so long as we recall that so long as we respect persons and so that people understand the risk that they're taking and are willing to want to take that risk, it's reasonable to recruit them into a study. The risks of sleepiness are manageable. In the Apple study, we had 250 person years of people using sham CPAP and 0 motor vehicle accidents. So I think there are approaches to do this safely. But that said, I think recruitment will still be challenging, even if IRBs will approve enrolling those patients in a long-term study. So next. Another important point, I think, is that different study questions may require different study populations. Can we advance? As Susan said, sleep apnea is not a single entity that's defined by a high apnea-hypopnea index, but a heterogeneous condition with multiple overlapping subphenotypes. And those can be defined by severity and pattern of hypoxemia, by autonomic responsiveness to events, symptoms, sleepiness, sleep fragmentation, and very likely by different genetic architecture in which the sleep apnea is exerting an effect. And many more, but those are some that come immediately to mind. We advance. And these different subphenotypes are likely to predispose to different health risks. So you might imagine that there's a sleep apnea phenotype that predisposes to cardiovascular risk, another to cognitive impairment. And I think it's likely that there are very many people with obstructive sleep apnea identified by an elevated AHI who are not at risk for any adverse effect. And when there'd be no point in including those in the study. So we go to the next slide. So I think the key question is, how can we identify outcome-specific markers of risk? Advance. And Susan spoke at some length about some polysomnographic markers of risk, such as the pattern of hypoxemia, or heart rate response, or other autonomic responses to events. Event duration, effects on sleep architecture. If we advance. Actually, this is just another a graphic of what Susan already showed, that patients with a high heart rate response to their events are at higher cardiovascular risk. So why don't we go on? Then there are physiologic markers of risk that don't come from a sleep study. But for instance, blood pressure non-dipping at night, which is more common in people with sleep apnea and may be, and we know is an important marker of risk factor for adverse cardiovascular outcomes, might be a marker that would identify patients with sleep apnea who are at risk of adverse cardiovascular outcomes, or impaired flow-mediated dilatation as a marker of endothelial dysfunction. Advance. And then blood biomarkers. Catecholamines were mentioned, and certainly it's been recognized for decades that catecholamines are elevated in sleep apnea, both at night and during the daytime. That may identify a group that's at risk for a variety of cardiovascular metabolic outcomes, and all the various omics measures that Susan mentioned. Next. And then genetic markers of risk may be useful, and not only for identifying people at risk, but in particular, I think it would be useful if we can identify gene by environment interactions between a genetic background and obstructive sleep apnea. And I don't know, because that may identify a group that's particularly susceptible to those effects of obstructive sleep apnea. And in whom intervention may be most effective. And I don't know any example for this in obstructive sleep apnea, but if you could advance this, you could advance the slide. There was several years ago, Jackie Lane published this analysis. It's known that there's a genetic variant in the melatonin receptor gene that's associated with increased diabetes risk. And what she showed was that risk is shown here for the individuals with that susceptibility genotype, that their risk for diabetes is particularly high for individuals who have an early rise time, but not for those who have a late rise time, suggesting a potential sleep intervention in the setting of a particular genetic background might be beneficial. And I suspect the same thing may be true for sleep apnea if we can identify the appropriate genetic background. Next. Okay, so these are questions that I thought we should discuss a little bit more. Sushil, I think you wanted to hold on this and ask some questions.
Thanks, Dan. Yeah, I appreciate that. No, yeah, we've got a number of questions that have come in. I was going to start off with one of my own here for you first. Given that we've had several randomized controlled trials that have been done that appear to be negative, if you will, looking at them. Do you think that we need to first identify what are the most vulnerable populations right now and put a pause on conducting RCTs, or do you think we can do these things concurrently?
Well, I think that it's true that we that of those multiple possible markers of increased risk, whether it's heart rate responsiveness or hypoxemic burden or some other measure, that none of them have been proven to be the right marker to look at. However, I think that I'm going to go to my second bullet point here, which is about our questions about adaptive study designs. I don't know that I would necessarily pause now from doing trials. I think there are enough suggestive markers that might help us to identify individuals at risk. But one thing I'd suggest is that and I think that maybe Doug will talk more about adaptive designs in a subsequent section. But I think it's possible, if you have in mind these possible biomarkers of risk, that you can assess those. And it doesn't have to be just one, but after a certain period of follow-up that has gone by, you can assess those markers and ask, is there evidence for a greater effect in individuals with and without these putative risk markers? And if so, you can adapt your enrollment strategy so that now you target only those individuals who appear to have a risk marker, which is really seems to be predicting the outcome. So I don't know that we need to pause at this point. I think we can think carefully about the literature that's out there. I think that a lot more is going to come out in the next couple of years. And of course, it takes about that long to plan one of these trials. So, I don't know that we should necessarily stop at this point.
So we have a question from Dr. Najib Ayas, which I think goes to your point about clinical equipoise. So he asked, when I talk with patients with severe disease and or even moderate symptoms, they almost universally tell me that there's no way they would agree to be enrolled in a study that might randomize them to control for prolonged periods of time. You also argue that there isn't clinical equipoise in these patients. Is it feasible to study these types of patients in prolonged RCTs where therapy is not offered? If not, what is the best way to get data on therapy effectiveness in these patients, given they may have a greater risk of OSA-related cardiovascular disease?
Yeah, well, I think it's a tough challenge because you're right. There are many patients who would not be willing to enter, to remain untreated for a substantial period of time. And I think that later, I think Greg will talk about some non-clinical trial approaches that I think may have some substantial limitations, but compared to the clinical trial. But to answer a little more directly, there are many patients, who, despite having symptoms, don't want to wear that CPAP no matter what. That they're as likely to refuse therapy as people are to refuse going to a clinical trial. And so I think there are many patients who are symptomatic and who are not enthusiastic about the treatments, who might well be willing to be randomized. And I don't think that we should exclude them a priori.
We have another question from Dr. Michael Twerry. So question is the selection of the appropriate study population complicated by the appearance that the recognized medical threshold of clinical significance may be influenced by the visibility of disability during a routine primary care visit? So just as an example, mild asthma is aggressively managed compared to apnea, where treatment is linked to evidence of daytime sleepiness.
Well, I think there's no question that for individuals with symptomatic sleep apnea who present for treatment, that they should be treated aggressively. I'm not sure that they're treated less aggressively than patients with mild asthma presenting for treatment, although our armamentarium may be less easy to administer. But I think there's no question that symptomatic patients seeking treatment should be treated. I think we do have to keep in mind that sleepiness, the most common sleepiness and fatigue, the most common symptoms reported by patients with obstructive sleep apnea are exceedingly common in the population without obstructive sleep apnea, and so many of those patients may have their physiologic abnormality of sleep apnea treated, but their symptoms not improve, and then we need to be looking for other causes.
Okay. And another question kind of goes to your last point here on the slide that's on the screen. Dr. Singh, again from University of Western Australia, brought this up. So again, when we look at current RCTs that look at secondary prevention, typically the participants are older, and they're more likely to be on cardiovascular disease modifying drugs than sleep clinic patients might be, for instance. Do you think it would be more meaningful to study the effect of CPAP for primary prevention rather than secondary prevention?
Well, I think it's I think it's an approach that we definitely ought to consider. Secondary prevention trials for cardiovascular disease have generally been, they've demonstrated that, lipid lowering, blood pressure lowering works. So I don't know that it should be any different for sleep apnea. That said, given the effectiveness of the conventional treatments to prevent recurrent cardiovascular events, it requires very large studies to demonstrate an additional benefit. And in fact, it may be that the sleep apnea related cardiovascular risk is adequately treated by those other interventions. So given that sleep apnea, especially with the prevalence of overweight and obesity, has its onset probably decades before overt coronary heart disease, it may be that that a primary prevention strategy may be appropriate. Starting with looking at a younger population. I think there are also some things that may be less reversible. If for instance, we see a strong association of sleep apnea with diabetes that's independent of body habitus, but trials treating diabetic patients treating their sleep apnea have not been, have been fairly disappointing for improving their diabetes. But there's evidence in diabetes that by the time you have overt diabetes, you have irreversible pancreatic islet changes. And so that's a setting where maybe you want to identify in that risk population earlier and intervene earlier. So I think that probably both strategies primary and secondary prevention are worth pursuing.
Thank you, Dr. Gottlieb. We'll go ahead and move on to the next section with Dr. Kimoff introducing our next panelist.
Thanks very much, Sushil. It's just would say also that it's been a great, well, privilege and pleasure to be involved in this process and the discussions we've had surrounding the AHRQ report and you know the discussions that have led to this session. And I think on behalf of everyone would also like to thank Sushil for his leadership in this. It's an even greater pleasure to introduce Doug McAvoy, who I think is known to probably just about everyone on the call. Doug has made major contributions in the area of outcomes research in OSA. He's currently at the Adelaide Institute for Sleep Health at Flinders University in Adelaide. And Doug, thanks very much for getting up early in the morning and joining us.
Thanks very much, John, and thank you to the organisers of this session for inviting me to make a few comments about this topic of challenges and opportunities for randomised controlled trials in the context of sleep apnea. Now, Dan has stolen quite a bit of my thunder, but I'll attempt to just address this by, if you can just go to the next slide, please. Perhaps just reflecting on the fact that randomised controlled trials, particularly looking at long-term outcomes, time-consuming, very costly. SAVE study, which conducted over about 10 years, cost a fairly modest $10 million US, around that mark. The Sleep Smart study, which is underway in the US in stroke patients, is, I understand, projected to cost about $45 million. So these are expensive, time-consuming exercises, and you don't know the answer to the studies until you get right to the end. So, you know, it's be a great advantage if we could develop strategies to reduce the time that a trial is undertaken and their cost. And I'm going to just make some remarks about those possible strategies in the context of explanatory trials and pragmatic trials. Now, these are sometimes overlap, but in general, explanatory trials are tightly controlled studies where you have experts working in a team to answer the question, can your intervention work in an ideal setting? So you carefully choose the study population and you try and answer that question. On the other hand, pragmatic trials are designed to answer the question, does an intervention work in a real world setting? So it's much more diverse settings, many different centres, and using usually simple procedures and interventions. And so next slide, please. So strategies to improve the efficiency of explanatory RCTs. Now, these might be trials, for example, where you're looking at long-term outcomes of CPAP intervention in obstructive apnea for stroke or depression, even motor vehicle accidents or the onset of dementia. And I agree with Dan's general approach here that I think it makes sense in these sorts of trials to enroll patients who have severe disease. Now, how you define that is, I guess, a question that Susan raised, but for better or worse, we've got the AHI at the moment, so that's what we would probably use. And then I think it'd be helpful to demonstrate that the patients entering in your study have the ability or capacity and willingness to engage in the therapy if they're randomised to it. And we used, as people know, in the SAVE study, a short run-in with a sham CPAP device, but you could even use a run-in with an active device. That's another possibility. So that's and of course, maximising adherence to the therapy, which Sanjay will talk about later. And then, you know, if you want to have an efficient study, then you need a relatively high event rate. So to get the event rates, you need to have people who are at risk of the outcome of interest because they carry known risk factors for it, or indeed if they've had an event such as a stroke or an acute coronary event, it makes them in the high risk category. And then I want to just talk about these adaptive trial designs, which Dan has alluded to in his previous presentation. So next slide, thanks. So the figure on the right of the slide here really gives you 4 different scenarios where you can talk about, or 3 of them, of adaptive designs. When you conduct long-term outcome studies, RCTs, the usual procedure has been to carefully consider and make assumptions about the event rates, the likely dropout rate or loss to follow-up and so forth, and use these factors in designing your sample. And you may, and most people will have designed in there an interim analysis. And the primary purpose of that is, I guess, to make sure that you have a study that's still viable and is safe and is meeting your targets in terms of enrolment. But you proceed right to the end, and that's the top example there. And you don't know the answer until you get to the end. You may need to stop the study because of futility or safety concerns, but generally you just proceed right to the end. Now, an adaptive trial design can also actually pre-plan to alter the sample size depending on whether your assumptions have been realised or not. If you've been too conservative in your estimates, you may be able to actually reduce the sample size. More commonly, you end up increasing the sample size because you've been too optimistic. Now, the other approach is to, and this is used very much in oncology research, is to actually look at how you're proceeding with the trial in terms of your intervention, and trying to statistically pick winners. If you might have, in oncology, for example, they talk about basket trials where you have one treatment but many different types or markers of a tumour, for example, and you have different groups of patients that you're targeting. And you look to see whether one group is benefiting more, appears to be benefiting more, and then you play the winner, if you like. You increase the recruitment of patients in that group as the trial goes on. So that improves the efficiency of the trial. And the other approach, which is probably more relevant to sleep apnea, since we don't know really with great confidence at the moment whether there are different subtypes, but we have some ideas, and they've been mentioned by Susan and Dan in their talks, is that you recruit people whom you think may be likely to benefit from the condition, but you look at these various aspects, be they clinical characteristic or PSG-derived physiological biomarkers, or even in fact you could design a study where you look at the acute response to CPAP in an active run-in phase. You might, for example, want to measure the blood pressure response. And so you'll store this information away, and then you may conduct one or more interim analyses, and this needs to be carefully modelled and designed before you start the study. And if it looks like your candidates at risk that you thought there are in fact bearing out to be informative, and those patients are showing greater benefit from the intervention in these interim analyses, you will then change, you'll enrich the population you're recruiting to the study to have more of those subjects come into the study. And in that way, you have a much more efficient trial. So next slide, thanks. Strategies to improve pragmatic randomized controlled trials. And in general, these studies, as I mentioned, are done in a much broader population, in a real world settings. They have, and they generally employ sort of fairly simple interventions. For example, you could think in terms of obstructive sleep apnea of, is it beneficial to screen for obstructive sleep apnea in certain surgical patient populations to improve their post-operative outcomes, length of stay in hospital? or is it helpful to screen for obstructive sleep apnea in long-haul truck drivers? And in these instances, what you would do is you do not randomize at the individual participant level, but simply at a group level or a unit level. So, and so you need in this instance to use a cluster trial design. And there are a number of different possibilities here, depending on the population and your intervention, that you should consider there. And they're just schematically shown there to the right in that figure. And the article by Sesler and Miles, I recommend you, for those who are interested to read, describes a number of these issues that I'm just talking about at the moment. And then I think you've got to consider in this instance the quality of the information you're getting, because you're now in a much more diverse setting, and you need to try and ensure that the quality of your outcome measures and your comorbid information and so forth is valid. And one of the strategies that's very helpful to do that is to embed these sorts of trials in a disease registry. For example, if you were looking at the outcomes in atrial fibrillation of screening for sleep apnea in atrial fibrillation populations, it would be ideal to embed that in an AF registry. Next slide, thanks. So I just want to close by making a couple of remarks about this question that Dan has raised about enrolling sleepy patients in randomized controlled trials. And this is my personal perspective about it based on our experience in SAVE. And in SAVE, what we did was that we surveyed clinicians in Australia before we started the study as to how they would feel about the ethics of enrolling people who were sleepy into the study. And we set certain parameters. We also asked them a question in relation to the degree of oxygen desaturation, because that frightens clinicians when they see people with very severe oxygen desaturation. So we set various parameters. We had this survey, and what we came up with the consensus was that we thought it was ethical to enroll patients in the study with sleepiness, but not very severe sleepiness, such that was their ESSs were 16 or more, or they had a history of falling asleep in the previous 12 months, either involving in an accident or a near-miss episode, or they were employed as a driver. And having done that, we were very careful to monitor every patient in the study at 6 monthly intervals by repeating those questions and those assessments. And if participant were to exceed the threshold of any of those, it would be notified to the core lab, where we had a clinician group that looked at the evidence for that and worked with the site PI to manage that patient's sleepiness. We required them to provide further information as to their recent history. For example, had they commenced opioid medication, had they begun shift work and so forth. And because, as you know, there are many different causes of sleepiness. It's not always due to sleep apnea, its treatment or otherwise. And the experience was in the trial that less than 5% of the participants in the study actually exceeded these thresholds as they proceeded through the study. And in many instances, with the help of the core lab clinical group, we were able to resolve most of the instances of sleepiness. The core lab advised the PIs, the site PIs, to cross over less than 1% of the patients from the control group to the CPAP group on the basis of this follow-up. There were about another 3 or 4% who crossed over of their own volition from the control to the CPAP group. But the net result of all this was that the regular reports to the DSMB and the final analysis did not send any alarms or find any evidence of an excess accident risk amongst patients in the control group in that study. So I think in certain instances it is possible and maybe even ethical to enrol patients with sleepiness in randomized controlled trials. So I'll leave it at that and be very happy to answer questions. Thanks.
Thanks very much, Doug. So I'll start off by asking, I mean, that's compelling argument in terms of safety at the threshold of Epworth of 16. Can you tell us if this has made you think that it could be reasonable to include more sleepy patients in a longer-term RCT?
Well, I think this is a clinical question, isn't it? Really, I mean, I think you need to go back to the clinicians who would be seeing these patients. I should just also add that I think one of the other aspects you need to think about is that we often talk about the patients that come to see us in sleep clinics. And of course, it's much more difficult to enroll them because they're seeking a solution to their symptoms. But if you go and you look at populations and you recruit from cardiovascular clinics, as we did for the SAVE study, you're seeing patients whose primary interest and concern is cardiovascular disease. And you're finding these people as part of your workup that are somewhat sleepy. And recognizing that obviously the sleep apnea may be one of the factors causing their sleepiness, you need to, in the consent process and the information given to them, you need to give them a clear understanding that some of this sleepiness may benefit from the intervention. But many of these people are very happy to enroll in the study because their attention is not on their sleepiness, it's on their disease that you're trying to intervene, or this outcome of interest that you have. And I think that would apply also for cognitive impairment and so forth.
There was a question submitted beforehand by Bajan Singh, which is kind of related. So Bajan asked, the inability to recruit sleepy patients leads to a biased sample. What adaptive design strategies can be used to overcome this? Is it reasonable to use stimulant medication instead of CPAP to enable recruitment of sleepy OSA participants for an RCT exploring long-term outcomes? I mean, as I'm thinking, the Jean-Louis Pepin and colleagues published the trial with pitolisant in patients with OSA who had declined CPAP for sleepiness, which seemed to be safe. I don't know, is that an option, Doug? What would you think about that, and how would that bias results?
Yeah, I guess then you've got the question, you really got two trials then, haven't you? You've got another intervention, which is the medication that you're imposing on people who are sleepy. I'm not sure, I need to think about that. Yeah. Maybe it's sort of factorial design you'd need 2 by 2 sure. Factorial, yeah.
There's another question that came, Peter Sestuli sent this in earlier, and I think it relates to the concept of adaptive trial designs. And you talked about selection of individuals and response and adapting the trials throughout, but what about therapy? So Peter asked, given we now have viable alternatives to CPAP, such as mandibular advancement therapy, positioning therapy, weight loss, hypoglossal stimulation, so forth, why do we persist with a one-size-fits-all approach, i.e. CPAP? Is it time to design studies where the intervention for OSA is tailored to allow the use of whatever treatment produces the best combination of efficacy and compliance in order to optimize outcomes?
Yeah, very good question, I think. And I think the answer is yes. We could have talked about that, but I guess with limited time. But I think that would make all the sense in the world. I mean, you're really wanting to intervene to decrease the exposure to the condition. And if you have other therapies, then a stepped approach might be very reasonable, or even at the very onset, patient preference for treatment might be something you'd consider as you enroll them. If you have another effective intervention, and mandibular advancement splints are a very good example.
I don't know if you're aware of one trial, the CHOICE trial run by Fernando Almeida in Vancouver, looking at mandibular advancements, splint, CPAP, crossover, and then the patients get to choose what they use. I don't know how the trial is going, but that seems like, an appealing patient-led approach, and perhaps that would be adaptable to registry studies as well.
Yeah.
Thanks. There's a couple of questions sort of dealing with the idea that that it may be, so is it reasonable to randomize patients who are not keen on treatment or assign people who are not keen on treatment to a non-treatment group, and people who are keen on treatment to treatment. So Brendan Keenan asked the question, can adaptive designs overcome a selection bias we discussed in previous sections, i.e. exclusion of at-risk patients or unwillingness of these patients to participate? In other words, if the RCT is enrolling the wrong patients, can adaptive designs help?
So I'm not quite sure how the question goes there. That's if you're enrolling people who are willing to participate in a trial that uses CPAP, but you'll have a whole bunch of other people who would say, no, I won't be in that because I hate that therapy, then you'll have a trial in patients who are of a particular characteristic. That is, they are very willing to undertake a mask treatment, and are they fundamentally different to the patients that really need the therapy? Is that what you think we're getting at there or not?
Yeah, I think possibly. Right, good. Well, listen, I think that actually leads very nicely into the next section. So I think at this point, thank you, Doug, very much again, and to everyone else, and we'll hand it over to Alan Pack to Greg Mason.
Well, thank you very much. And this is obviously a very, very interesting discussion. I think what we've heard in some of the earlier discussions, Dan Gottlieb has indicated that if you exclude excessively sleepy people, you're tending to bias the results to the null. We've heard from Dr. Ayas that patients themselves of that type are very, pretty reluctant to be put into randomized trials. And so it does bring up the idea of whether we could think about alternative study designs. And that's what's talked about in this section. What are the alternatives? The panelist here is Greg Mason. Greg's been the principal biostatistician at the University of Pennsylvania Sleep Center since the late 1980s. He's published, probably one of the more published biostatisticians in our field, and he's got particular expertise in propensity score matching. He's published a theoretical paper with Rubin, who was the discovery, if you like, of the person who proposed the idea of propensity score matching. So I think Greg is really highly appropriate to give this, and I'll turn it over to you, Greg, and hear what you think.
Great. Thank you very much, Alan, and thanks to the organizers for inviting me. Next slide, please. So RCTs are considered the gold standard for evaluating relative treatment effects for good reason. Randomization promotes balance in measured and unmeasured characteristics, and exposure is the only systematic difference, with allowing for unbiased estimation and valid causal estimation. There are limits to the questions RCTs can answer. Subjects may decline randomization if alternative treatments are available. Subjects willing, eligible, or available to enroll into an RCT may not be similar enough to clinic patients for adequate external validity. And RCTs may be prohibitively expensive. Next slide, please. So when can a PS design help? There is a non-willingness to be randomized. So for example, FDA, the Center for Devices and Radiologic Health, accepts PS designs to overcome this. For example, for new motion-sparing lumbar and cervical spine devices versus fusion. FDA requires a very rigorous process, and this process might be a model for others to use. The matching must be done with no outcome data in sight. A consensus of good balance has to be determined prior to unblinding, and there has to be a rigorous demonstration of covariance balance accounting for the design. Typically, sponsors of these types of trials submit a PS memo and FDA reviews it, and only when there's consensus that it's likely that selection bias has been addressed is the database open for outcomes analysis. PS designs can also help when the inclusion criteria of RCTs can reduce external validity. We've heard about this today, that past studies, RCTs have excluded very sleepy subjects due to ethical concerns, And also, RCTs of PAP have recruited subjects outside of the sleep clinic, and this could reduce external validity. Finally, there's an opportunity with large data, for example, market scan databases, to really contribute to the advancement of medical knowledge. This is especially true in label expansion when we're comparing two different already marketed devices. So, for example, in the on-target study, which compared telomorphin to ramipril, the primary outcome was a composite of myocardial infarction, stroke, hospitalization for congestive heart failure. And in this study, the authors concluded that, in contrast to on-target, which took approximately 7 years to complete and cost tens of millions of dollars, their study took approximately 12 weeks to implement at less than 100th of the cost. It's an interesting paper. The primary results were identical between the randomized clinical trial and this very well-conducted model of what is possible. Next slide, please. So following Rubin, the goal of the PS design is to mimic to the extent possible the good features of an RCT and thereby strengthen the validity of the causal inference. PS is the probability of being in the treated group conditional on all relevant baseline covariance. There's two implications of this. One is that PS is called a balancing score, such that if two subjects have the same propensity score, their baseline covariance distributions are approximately the same. And given two subjects with identical propensity scores, one treated and one control, analyses may proceed as if the subjects were randomized. PS designs require that no unobserved confounding assumption in order to provide valid treatment estimates. When comparing PAP users to non-PAP users, it is extremely critically important to include variables that account for healthy user bias and healthy adherer bias. Next slide, please. This is a graphic that was created by my colleague Brendan Keenan. And I'll just put your attention to the left-hand box in the middle there under observational study. In an observational study, the two treatment groups are not necessarily similar in their baseline characteristics. So, for example, the treated group may have a lot of subjects that have high propensity scores, like the purples. These are subjects that have characteristics more often found in the treated group than the control group. In contrast, the control group has more light blue circles. Those represent characteristics that are more likely in the control group than in the treated group. However, if you look at the lower right-hand graphic, that shows one of the several ways of conducting a PS design. This is called PS subclassification. So you take the entire group that's available for study, and you break them into 5 little population subclasses. For example, Q5 contains subjects that are more often like the treated group, and Q1 contains more subjects that are like the control group. However, all of the subjects in Q5 have the same covariate distribution by the definition of the propensity score. That means you can treat the subject in Q5 as being either randomized to treated or control, albeit in a ratio of 5:2. In contrast, in Q1, that contains the group of subjects that generally look more like controls. But all of these subjects have the same covariate distributions. So you can treat the subject in Q1 as being randomized, albeit in a ratio of 1:5. And there often are subjects in the control group that are not similar enough to subjects in the treated group, and those subjects are trimmed from the analysis. The analysis proceeds by calculating the treatment effect within each of these subclasses, treatment minus control, and then statistically averages over these 5, what are essentially 5 mini clinical trials. Next slide, please. The no unobserved confounder is essential and vital in order to produce valid estimates in a non-randomized trial. There are methods to evaluate this assumption. For example, the E-value, which is described by Vanderweel and Ding in 2017, determines the magnitude of the associations between a theoretical unobserved covariate with both the exposure and the outcome of interest. that would be required to nullify the observed treatment effects. If this magnitude is large, then the PS design is demonstrated to be robust against the unobserved covariates. So, for example, a conclusion might be the observed risk ratio of 3.9 could be explained away by an unmeasured confounder that was associated with both the treatment and the outcome by a risk ratio of 7.2-fold, above and beyond the measured confounders. But a weaker confounding could not do so. So this would indicate that the results are robust and that we can feel more confident that there isn't, even though we tried our best to include the important confounders, if we miss one, they would have to be really large in order for us to nullify the results of the PS study. Thank you very much for your attention.
Okay, well, thank you very much, Greg. So perhaps I'll just get this started. There was a couple of points that people made in the previous thing, and I think I should probably just explain them and then ask you a question. Dr. Singh, he said, yes, it's certainly true that in the SAVE study, excessively sleepy people were enrolled, but the average Epworth in the SAVE study, despite that, was about 7.5. So the majority of these people in the SAVE study were not excessively sleepy. And Dr. Gunaratne put something in the Q&A where he said, look, even if the thing is approved, even if a study like this is approved by the IRB, if somebody who's excessively sleepy, who's randomized into the control group, has a major accident or something, the university he must have had some legal opinion or something, the university is not exempt from a lawsuit, even though it's been IRB approved. So I just wanted to make these 2 points. Now, Greg, this whole area seems to generate a load of passion about whether this type of study design is really for us and moving forward. It's been argued that the whole thing is fraught with difficulties and so on. Apart from the unrecognized confounder and the ability to try to control for that, what are the other challenges to this particular study design?
Well, I think that's the primary challenge of making sure that you have the right variables and you don't have residual confounding that you haven't controlled for. In a lot of ways, this type of design has a lot going for it in terms of being efficient. There's a lot of creative ways of constructing such a design. For example, you could have a registry, a prospective registry, and then you could compare that prospective registry to a large database that might be available. The whole point is that if you have a rich set of covariates, so it's unlikely that you're missing important covariates, you can generate a valid causal estimate of the treatment effect.
Okay, so Dr. Patel, you've raised your hand. You want to ask a question or make a comment?
Oh, I think Dr. Maslin may have answered it with his point about the registries. And the question was really, is this the area where PS approaches and designs, may thrive when there is a registry?
Yeah, this is one place that is currently being looked at, especially by FDA, in terms of trying to generate data from real-world evidence, from real-world data, and converting that into real-world evidence. And one of the ways that FDA is looking into converting real-world data into real-world evidence is through the construction of a well-conducted PS design.
Okay, there's another question from Dr. Redline, or a comment rather from Dr. Redline, which is basically, let me just try and find it, basically where there are methods to assess unmeasured confounding. A review comparing RCTs compared to propensity score matching studies in cardiovascular disease have shown systemic overestimation of effects with the propensity score matching. How practical can the issue of unmeasured confounding really be achieved practically? So there's 2 practicals there, right? How can the issue of unmeasured confounding really be achieved?
Well, really, the crux is in the design. And unless you have a really good design and you've really thought about what those factors should be, you're not going to be able to have a robust treatment effect estimate. So in the design that we're thinking about comparing users and non-users of CPAP, we recognize that the healthy user and healthy adherer bias are absolutely critical, and that we have to be really, really careful and do more than what we're used to doing in measuring things like diet and activity and other factors. So that's, I think, the way out of the conundrum. In terms of the literature, I think the literature is mixed, and it's hard to judge some of those studies where there are differences between RCTs and observational studies. They really highly depend on the quality of the observational studies. And also, there is some literature to suggest that when there are differences, they're addressing different questions. So, for example, an RCT may address a particular question, but they're addressing a particular question to a very highly stylized set of subjects that aren't necessarily similar to the clinic. So when there's differences, it may be that the answers are different because they're addressing different questions. I'll call attention to the Fralib article that I have a reference for, which was a very well-conducted label expansion study. It was a replication of the RCT that had previously been conducted, and the results were dramatically similar.
Okay, there's another question here, a really important question from Mark Boulos, and it says the SAVE trial had a pre-planned propensity score matching scheme that demonstrated a reduced risk of incident stroke with good CPAP adherence. However, this finding has not gained traction in the general literature. Do you feel that PS approaches will be widely accepted over RCTs?
Well, I think it depends on the application. So I got started doing propensity score analyses looking at medical devices, and modern devices are motion sparing, and patients refused to be randomized to a study in which they could get fusion. So the question at that point was, well, do we just stop new advancements in medical devices because we can't conduct trials, or do we do something else? So that really spurred a lot of work at FDA in trying to come up with the best practices to come up with what's considered, according to law, valid evidence of safety and effectiveness. And there's been a number of recent FDA approvals. I've been involved in a number of them in medical devices using propensity scores to overcome that. So I think there's a question of, if we can't answer the question with RCT, we have to do something. And I think propensity score analyses are more difficult in one sense than a randomized trial, although the randomized trial may be much more expensive. But you have to be very careful when conducting a propensity score design. You have to do a lot of work in preparation in terms of the covariance set that's appropriate. And you have to do a lot in terms of having processes where the design is entirely determined prior to looking at any outcome data.
Okay, there's another comment. It's really just a comment from Brendan Keening. And what it says is, could the overestimation of effect estimates and propensity score designs mentioned by Dr. Redline actually reflect a bias in RCTs? For example, if RCTs have enrolled the wrong samples and are therefore underestimated the true treatment effects. So the assumption is the bias is propensity score. He's arguing the bias could be the other way. What do you think of that?
Well, I think that's true. There was a session by the clinical epidemiology at Penn about comparisons of a couple of years ago, and a number of statisticians kind of been talked about the fact that when the trials have different results, is it a lack of the propensity score designed to replicate RCT, or are we talking about different questions, different populations? And I think the conclusion is that you have to look at it on a case-by-case basis. And I think it's certainly conceivable that if you have a convenient sample for patients willing to be randomized, and those populations are obtained in areas other than sleep clinics, you're going to have a population that differs substantially from the sleep clinic population, and the results aren't necessarily going to be relevant for sleep patients that are seen in clinics.
Okay. Now, Dr. Sanjay Patel, I think you raised your hand. You want to make a comment?
Yeah, I guess one concern I have about using propensity score models in this to address this question is that we're really comparing no treatment to treatment. And typically this comparison, the use of propensity score models is when you're comparing two active treatments, because the choice of a patient to choose between two active treatments is somewhat idiosyncratic. But when you're choosing no treatment versus active treatment, that really is getting at sort of a healthy user effect that you mentioned, which may have much larger effects. And so I wonder if you had any examples, Dr. Maislin, of using a propensity score model effectively when it's a choice of, treatment versus no treatment.
I think that's a very important point, perhaps the most critical point. If you read the Freilich paper, one of the reasons that was such an excellent model to follow was that it was comparing new users of two different active treatments. So the populations were very similar to begin with. In our case, we have the challenge of individuals that select not to use treatment, that they could be fundamentally different in certain ways. And that's why the evaluation of healthy user bias and healthy adherence is so critical. We're going to have well-designed trials in this situation.
And I'll just make a comment, Greg. I mean, there is a literature on how you assess healthy user and healthy adherer. There are tools out there to do that. So that's where we are. There's a couple of last things here. So one is from Anthony Jackson, and he says, is there a place for use of historical controls gleaned from a large all-comers registry? Can you use, historical controls in this area?
Well, you certainly can use historical controls. The only criticism of the use of historical controls is has medical practice changed? So the use of historical controls certainly is a viable option as long as those historical controls are being treated in the same way as current controls would be.
Okay, and I think this will be the last. Dr. Redline sent a comment in the chat. It says, keep in mind that differences in generalizability, clinic versus community, does not mean one is biased versus another. We need to be careful on how we extrapolate data. It is not that there necessarily is a wrong or right population. I wonder what your comment would be to that, Greg.
Oh, I agree with that. As I commented earlier in this symposium discussing this issue, the conclusion was that real-world data sources and clinical trials may not have the same answer because they're addressing different questions.
Okay.
And the questions developed by, essentially the questions are, what population are we making our inference to?
Yeah, there's one last comment here, but I think I have to move on to Sheil, right?
Yeah, no, I think we do.
Yeah, there's one comment from Nalika. We're trying to get to that, Nalika, okay? Gunaratne, okay? Okay, thanks very much, Greg.
So I want to thank the 90 participants who are hanging in there for the last subsection of the last section of the sleep meeting on a Sunday night, and want to turn it over to Dr. Sanjay Patel from University of Pittsburgh Medical Center, who is a pulmonologist and epidemiologist, to talk about PAP adherence.
Great, thanks a lot. And thanks for everyone who's sticking out to the very end. Next slide. So I think in thinking about optimizing PAP adherence, I think the first thing that we just really all need to be clear about is that you can't describe adherence with a single number. You'll see on the left panel there data from one of the Adelaide trials, but this has been shown both clinically and in many research studies that adherence really has a bimodal distribution. You have a group of people who have low adherence, virtually zero adherence, and then a second group that is sort of centered around 6 or 7 hours. And to try to describe this with a single number, you don't really understand what's going on if you do that. The second is that we need to recognize that adherence peaks early and then wanes over time. And so you really can't compare trials that have different durations of follow-up. And this has really been one of the things that's frustrated me in people who criticize the SAVE trial, where they're looking at mean adherence over 3.7 years and criticizing that for not being as good as their clinical adherence at 3 months. That's just sort of an unfair comparison. Next slide. So I just want to highlight, I guess, before I go through this, that these thoughts about design considerations of how to optimize PAP adherence for future trials comes from a number of conversations I've had with many people, including, in particular, Amy Sawyer and Jesse Becker. But the thought is that there are a number of issues that we really need to think through and make sure we're doing a better job with as we try to design future trials. The first has already been highlighted by Dr. Gottlieb and others, is that we want to select populations that are most likely to be adherent. I've listed some of the things that we know influence adherence. Now, in general, when we design trials, we try to pick the population that's most likely to benefit, so the population that's highest at risk, as Dr. McAvoy pointed out. But I think we really need to recognize that adherence needs to be a component of this, in that if we recruit people who are going to be poorly adherent, we're going to have problems in showing efficacy. And so, things like using run-in as the SAVE trial did make a lot of sense. We need to learn more about how to design the run-in to be most informative. The other thing is if we do get to a point that we have effective propensity score models, then we can predict adherence. And that's one of the challenges we have right now, is that we don't have good propensity score models to predict adherence. And that needs to be sort of something that's invested in developing more evidence for. The second thing is we need to make sure that we're incorporating proven interventions to increase adherence. Not only things that have been proven to improve PAP adherence, but we need to recognize that PAP use is very similar to other health behaviors, whether it's alcohol abstinence or weight loss, and we can use the wealth of data from other behaviors to understand how we can increase adherence in PAP trials. The third is we need to make clear that we need to tailor adherence plans to the trial itself. So we need to have clear knowledge of what the adherence goals are for maximizing the trial outcome. So we need to know what the dose response for the outcome we're looking for is, and in the population of interest. We need to know the salient barriers and facilitators in that population of interest. And we need to do some pilot studies to understand that we've tailored the adherence intervention in that population of interest. And then finally, we need to do, as a field, a much better job of having robust methodologic standards regarding PAP adherence. So we need to include adherence expertise from behavioralists in trial leadership. We need to have explicit adherence protocols, both so that all the sites in a multi-site center are doing the exact same thing, and we know that they're all doing things that will maximize adherence to the best of our knowledge. And so that we as a field can learn from what worked and what didn't work in prior trials. And then finally, we need to make sure that we're investing in proper, in all the things that we know will maximize adherence. So there needs to be adequate site training, especially if we're using staff that are not sleep experts. There needs to be frequent retraining, since there is staff turnover over the long-term duration of these long-term trials, and then we need to have fidelity assessments. Next slide. So I'm not going to go into detail of all of these potential interventions that could be incorporated. I'll point out that most of the trials to date have focused on mask selection, education, and troubleshooting. In general, these are effective strategies, but there are opportunities to do better. For example, not being limited in the masks that we use for a given study because of financial issues. But in addition, I think there are a number of additional strategies that we need to incorporate in future trials. So behavior modification is probably the one intervention that has the most potential, has shown the largest effect size in improving PAP adherence, that hasn't been fully incorporated into prior trials. Probably that's because most study PIs and staff, if they're sleep techs, are not fully trained in behavioral interventions. And so that's something we just need to do better with. Telemonitoring is starting to get incorporated. The Sleep Smart trial has a strong telemonitoring component, but we really need to do a better job of understanding what the optimal response is when you detect in real time that somebody is having low adherence. And then you can see a number of other things like giving participant feedback, using social support, both from partners as well as peers, using incentives such as lotteries or awards or gamification where participants are competing against each other. And then also addressing comorbid sleep problems. There's a fair amount of evidence that increasing sleep duration, regularizing sleep patterns, treating comorbid insomnia will allow CPAP adherence to be optimized. We need to do a better job of incorporating that from a behavioralist standpoint into the protocols, and that could potentially be given in the control arm, and that might help improve the ability to recruit sleepy patients, since this may be contributing to the symptoms in a sleepy population. Next slide. I will highlight this important area that needs much more research, is that we need much more research on what happens to CPAP use beyond 3 months. Unfortunately, because of CMS criteria, we all just focus on the first 3 months. And we don't know a whole lot about what are the triggers for people abandoning use after 3 months, but we know adherence drops if we don't do much. I think it's fairly clear that behavioral interventions have much more potential to improve adherence beyond 3 months than troubleshooting. We need to utilize knowledge from sustaining other health behaviors, again, using the AA model or weight loss interventions. I have highlighted 2 studies that have shown that it is possible to maintain adherence beyond 3 months, one using phone calls from a psychologist, the other using telemonitoring with text messaging that offers behavioral messages. And so it seems like, again, that behavioralist type interventions are probably the focus that we need to use for long-term interventions. Next slide. And then finally, I'll just point out that we really need to be clear that we're targeting or tailoring the intervention for the population in that trial. So these are data from the Philips Encore database showing that adherence varies greatly across demographic groups. So you can see in the top left, 18 to 30-year-olds in blue are women. You can see this rapid adoption by day 2. There's maximal CPAP use, and then there's a steady decline with a very fast decay and these fluctuations where these young people are abandoning CPAP on the weekends. And that pattern is very different from older populations, 80-year-olds, who take much longer to master CPAP use, but then have much less of a decay. And so you can recognize that how you tailor an intervention, the barriers for the population are going to be very different in young women if you're doing a pregnancy-related study versus older populations if you're doing a dementia prevention study. And we need to recognize that we can't just rely on clinical data that's been collected on predictors of PAP adherence, which have by and large been focused on rich middle-aged white men. Finally, I'll just point out that there is this tension if we want to maximize CPAP adherence and try to pick out those people who are going to have the best adherence, in that we know one of the strongest predictors of poor adherence are social determinants of health. And so if we want to have trials that will encompass health equity, we really need to make it a priority to understand and develop interventions that are going to minimize those, or else we have to choose between sort of not including those populations or else having low adherence. So it becomes a priority to really understand CPAP adherence in those populations. I'll stop there.
Thank you. So I want to start with one question. You know, I have patients that only sleep 4 hours, so 4 hours of adherence might be perfect for them. And there's the idea of sort of apnea burden. Should we be either having people have actigraphy devices so we know how long they sleep, and or asking them how long they sleep so that we could really sort of flip adherence backwards and really more report out on sort of % of sleep time that people are using the machines?
Yeah, that's a great question. I think we don't really know what the relevant measure is, whether it's apnea burden or whether it's some other combination. I think that those are data that we could use, some of the cohorts that Dr. Redline is using, to sort of try to explore is it better to have to only sleep 4 hours? Is your risk from sleep apnea less than because you have less apneas that you're exposed to? I think we have longitudinal data where we can try to answer those questions.
And we have a question that says, why is peer support long-term connection not included in improving adherence? As you mentioned that over time, the adherence really drops off.
Yeah, no, I think, honestly, I think the practical issues that people have been confused about how to get IRB approval for using peers. That's something that we really need to overcome. That's just a technical issue. But Sai Parthasarathy in Arizona has been working on this. I think there are easy ways, even trying to get people who, early on were successful participants in a trial to then be peers that can support other participants that come later in the trial.
Dr. Schroller asked, do you see a similar signal for a decrease in adherence over time in pharmacologic trials?
I mean, I think it's clear that in the HIV or diabetes or blood hypertension, that there is a drop in adherence over time. So I think these issues are kind of related. Understanding what those fields have done to kind of boost and maintain high adherence is something that we need to learn more from.
And there's a question from Dr. Redline. How much does poor adherence reflect behavior and comfort versus possible differences in OSA subtype? Perhaps a substantial of poor adherence needed a different intervention. And is there other ways we can sort of address these adherence problems?
Yeah, no, great question. I think the Yale group has suggested that there are endotypes that predict poor adherence, whether that is a reflection that those groups are not at risk for the symptoms, the sleepiness and things like that, because experiencing an improvement in symptoms is one of the strongest predictors of adherence. But it may be that there are certain endotypes that just don't do well with PAP. That's certainly something that we need to study more. But I think, I think that's fairly easy to do now with some of the endotyping, sort of non-invasive endotyping that's available now.
And we sort of touched on this with previous discussions, but in terms of adaptive treatment trials and not only potentially, as Dr. Redline suggests, maybe moving to a different type of PAP therapy, but also then just to other treatments like the mandibular advancement devices. And my question for that is, do you think that's feasible, both cost and sort of implementation wise?
Yeah, I think unless there's support from industry, I don't see it being financially viable from an NIH model. From the standpoint, I think in general, we've done fairly good as a field in getting people adherent for 3 months. The challenge is, how do you get people to stay adherent beyond 3 months? And I'm not sure that saying we're going to offer them hypoglossal nerve stimulation is really the answer for why. I just don't think we truly understand why people decide 6 months or 12 months out they're going to stop using their CPAP. It may be that some subset of those just feel frustrated with CPAP as their life experiences change. But I'm just not sure that that's the group. Usually the group that fails CPAP early.
And there's a question of, do we think some of our past failed trials are due to poor adherence? I mean, do we think that's why the trials failed?
I think that's $1 million question, right? Either CPAP doesn't work, or it's just the adherence hasn't been high enough. That's the fundamental question our field faces, I think.
Dr. Walia, should we push for adherence in asymptomatic and healthy individuals? As you know, they're a harder group to get buy-in from.
So, someone asked about their brother. I mean, if my brother was asymptomatic and had an AHI that was elevated, I tell him to ignore it. I mean, all of the evidence points to symptomatic populations that benefit from CPAP. I think we as a field underestimate the burden of CPAP, the inconvenience of sleeping with a mask on your face night after night. I think that's really asking a lot of most patients, especially if they have no symptoms.
I mean, I guess as a neurologist, I get a lot of the stroke patients who, if I had a 50-year-old who had a stroke and is asymptomatic, and nothing else is found as the cause of stroke, and you have severe OSA, should you get treated? I think there are certain populations and certain outcomes that is the $1 million question of, do we need to treat AFib? Do we need to treat it for stroke? Do we need to treat it for previous, heart attack, or, those groups of people?
Yeah, it may be that it's helpful for them. I don't know that we're going to answer that question before we answer the question in the symptomatic people. And it may not be sleepiness, right? There may be others. I mean, I think we all know that there are other symptoms that people gain benefit from. So I don't mean to say it's just sleepy people.
And one question is, if we were already going to treat sleepy people because they're sleepy and symptomatic, should the people we actually need the question and this trials for is the asymptomatic one? Those would seem to be the ones you'd actually more likely change care and recommendations on.
I think we either are going to have to come up with ways, much better ways to maintain long-term CPAP adherence, or develop new treatments that are much more tolerable that patients are willing to use if they're asymptomatic.
Thank you.
There's a comment in the Q&A from Dr. Gunaratne. It's a pretty long comment. Maybe we could unmute him and he could actually explain it himself if he's still there.
Let's see. No, he's not on here anymore.
He's gone.
Yes.
Well, I'll read it. It said, could you comment on the impact of feasibility of having a control arm and an RCT? Because that's really what we're talking about here. For example, I mean, he had a randomized trial, which was funded by NIH, for mild cognitive impairment. We found that in a small survey sample, 8 of 9 geriatricians would discourage their patient from participating in a long-term 1-year research study that included an OCPAP arm. We currently have to screen approximately 100 patients for every enrolled subject. With this added element, patient provider discouraging participation, he's saying that one possible estimation is that we need to screen over 500 patients to identify one eligible and enrolled subject. So he's got practical experience in this funded study from NIA.
I think Nalika makes a really important point, and a point that's really challenging our field, and we need to really change the dynamic on. We've done an incredible job of doing outreach and telling everyone that sleep apnea causes every bad disease under the sun. And unfortunately, we've convinced a lot of people without showing them good data. And so, I mean, this is my experience too, that there are physicians, especially sleep physicians, who won't let their patients be randomized, even though we don't have strong data. Even if the patient is willing to be randomized, the physician will counsel them against it. For these geriatricians, I mean, my suggestion to Nalika is he make those geriatricians wear CPAP for 2 weeks and then see what they say. But honestly, like, I think we have to be more cognizant of what the evidence base is, and we have to be more nuanced in what we tell other physicians. You know, if you look at the cardiology literature, the ischemia trial that was completed a year or 2 years ago now randomized patients with angina to PCI versus no intervention. Who could imagine that you telling your brother you're having angina that we know is cardiac, you have a positive stress test, and we're going to randomize you to not intervene on that. But that intervention that trial showed that there wasn't a benefit, right? We don't know if CPAP prevents cognitive dysfunction. And how are we ever going to find out if we force every single patient to use CPAP?
There are a couple more questions, but I don't know if we want to leave it there. I'll pass over to Dr. Patil to decide.
I think we'll be respectful of everybody's day start or evening, depending on where they are. So we'll just wrap up with a few concluding remarks. If we can go to the next slide. So want to just thank the panelists and the moderators. This was a great session, and hopefully it just stimulated some thinking about how things might move forward. certainly, with the draft report from the AHRQ, we'll have to see what the final report looks like. But it certainly was, prompted a lot of thinking and a gathering of many societies that helped contribute and endorse one of the responses that went to the AHRQ. And you can see some of those societies that are listed here on this slide. Next slide. So within the response, I'm not going to belabor this too much because we spent the last few hours talking about this, but really in the response, we asked AHRQ to consider, while they did indicate some areas for future research. We really think that this report can serve as a roadmap for the research agenda moving forward. And so, one of the points again was looking at alternative RCT designs, as Dr. McAvoy has discussed. Next point. As Dr. Maslin has talked about, could using propensity score matching, particularly using cohort studies or registry trial data or registry sets. Next point. And, looking at other markers like Dr. Redline has talked a little bit about in terms of molecular biomarkers, genetic markers, and other novel physiologic measures in terms of enhancing our prediction of outcomes. Next point. And finally, as Dr. Gottlieb had talked about, how do we select specific patient groups? And as Dr. Patel has talked about, how do we approach CPAP adherence for these longer term studies? Last slide. So in terms of future goals and moving forward, with this report, CMS is responsible for reimbursement for treatment that is reasonable and necessary based on the strength of the current evidence. And, looking at the current evidence base, there's some areas where we think we have strong evidence, particularly with symptoms perhaps, but perhaps not these other longer term outcomes where we worry about with cardiovascular outcomes and other associated comorbidities. And, really, perhaps the next step is engaging with funding stakeholders to lay a roadmap for what these future research areas should be. And within ourselves as a sleep research community, we want to be able to collaborate and further establish standards for what these studies should look like going forward. And finally, we've had a pretty vigorous discussion here about, whether we're in clinical equipoise, and Dr. Patel has made a nice concluding remark in his statements about, perhaps whether we've put the cart before the horse in this case. And so these are issues that I think the field are going to have to address. And so with that, thank you everybody for your time this evening or this morning or wherever you are, if it's the middle of the night. And please continue to have a good meeting at Sleep 2021 and look forward to seeing you in person sometime soon.